Hey guys, welcome back to it. So today's lecture is going to be a little bit different in that we're really only going to be covering one disorder. And actually, the majority of what we're going to be talking about would not be considered abnormal psychology. It's going to be very, very normal. But because sex and gender are such complicated and nuanced subjects, I feel that it's important to start off this conversation in terms of reviewing what is normal as far as sexuality and sexual and gender identities go, to kind of clear the air and have that established before we can move forward into what is abnormal, what's clinical, what's diagnostic. So, up first, what's normal? What is normal is any of these varieties of sexual identities, gender identities, etc., etc. For pretty much all sexual identities, all gender identities are going to be considered normal. This is an assortment of labels on this particular slide, and I've selected these labels in particular to highlight because they're the labels that correlate with the commonplace LGBTQA plus acronym. So, what is a sexual identity? A sexual identity is an identity that describes who you are attracted to sexually. So, sexual attraction could be a way of thinking of sexual identity. So, first of all, we have heterosexuality, which would be kind of the majority identity within our country currently. This would be anyone who has sexual attraction to the different or opposite biological sex. Homosexuality would be sexual attraction to the same biological sex, and more specifically, we use the term lesbian to refer to a woman who's attracted to a woman, and gay to describe a man who's attracted to a man. So that's where our first two letters come from. Bisexuality would be sexual attraction to both biological sexes, and then asexuality would be no sexual attraction to either biological sex. So that's going to be where B comes from. The A, some folks like to say that it stands for asexuality. Some folks like to say that the A stands for allies. But because asexuality seems to be the least talked about of the many identities, I do like to highlight it here. And at this point, I would suggest pausing this video to switch gears and view Chantal in her TEDx talk about asexuality. It's a really interesting talk. It's maybe 10-ish minutes long. Chantal's a teenager in the talk, and she's just kind of talking about how she came to realize that she was asexual and what that process was like. And she goes on to describe what asexuality is. It's a really interesting video that just kind of highlights what this identity is and gives one example as to this young woman's experience with this identity. So those are sexual identities. And again, this is not an exhaustive list. There are so many other terms that could go on this list, like pansexuality, for instance. But I'm kind of, again, making a point to highlight the terms that correlate with the popular LGBTQA acronym. Gender identities are identities that relate to how we identify. So, if a sexual identity is who we are attracted to, a gender identity speaks more to how we view ourselves. So, a cisgendered identity would be someone whose gender identity matches with their biological sex. So, someone who was born male and who identifies as a man, masculine, or someone who was born female and who identifies as a woman, feminine. Transgender is a term that we use to describe someone whose gender identity does not match biological sex. So, someone who was born biologically male but identifies as a woman, or someone who was born biologically female and identifies as a man. Typically, we use the term trans woman or trans female to refer to someone who identifies as a woman, and trans male or trans man to refer to someone who identifies as a man. So if we're adding woman or man or male or female to the end of the prefix trans, that term is referring to how the person identifies, not the natal sex that they were born as. And then finally, we have Queer questioning would be the various terms that are attributed to the Q in this acronym. In general, questioning describes someone who is kind of unsure as to where they fall within these categories. Part of that has to do with the fact that these are categories in and of themselves. So even though we're looking at a much more diverse grouping of sexual identities and gender identities rather than just kind of the cis het norm, we are still looking at a very black and white categorical system here. And so many people are questioning because these are boxes. And so that kind of puts added pressure on a person to find their box versus just kind of existing where they exist, as one would do with a dimensional system, which we'll talk about next. Queer can be a bit more of a general term referring to just kind of an existence within this territory. Queer can also be a term to refer to someone who is kind of moving a little bit more so outside of the black and white dichotomy of man versus woman. So someone who is maybe attracted beyond just those black and white boxes, or who identifies beyond those black and white boxes of man versus woman. So those are some of the things that will go with the Q. But as I mentioned before, the reality of the situation is much more dimensional in nature, which is why I really like the genderbread person, and I like to spend time in class focusing on this depiction as well. So the genderbread person is a really nice way to just kind of break down people along several different dimensions, relating, broadly speaking, to the issues of sex and gender. So the different dimensions that we're going to talk about are gender identity, gender expression, anatomical sex, sex assigned at birth, which is more of a category, and then who the person is sexually attracted to, as well as who the person is romantically attracted to. So we are kind of breaking down the ideas of sex and gender a little bit more specifically than what we talked about on the previous slide. So, gender identity is how a person identifies. Does a person identify as more of a woman, as more of a man, neither, both, somewhere in the middle? Something that I really like about these dimensions is that it does allow for more than this. Kind of hetero dichotomous man womanness, where you guys can see that many of the terms on the previous slide, like heterosexuality or homosexuality or bisexuality, are still definitions that exist on the basis of two biological sexes and two options, man versus woman, versus when we kind of open this up into a dimension, we've got all of this beautiful space in the middle versus just those two anchors. So gender identity, again, is how a person identifies. Gender expression is how a person likes to express themselves, and this may match up with identity, it may not. There are societal reasons that expression may not match identity, but also people are unique and different, and you'll have folks whose identity might not match up with expression in the way you might expect it to. So with gender expression, we've got feminine and masculine as our anchors on that dimension, and then again, a person can be anywhere in the middle, both, neither. Anatomical sex would be what a person's primary and secondary sex characteristics look like. This is something that is obviously related to birth, to hormones, to chromosomes, but surgery could also potentially impact this, as could taking various hormones. Anatomical sex, broadly speaking, exists on the spectrum between female and male, with again, there being plenty of space there in the middle. It can be important to acknowledge the sex a person was assigned at birth. Sometimes we'll refer to this as natal sex or birth sex. And in general, we still tend to use a category for this one where a person's either assigned the sex of female, male, or intersexed. Intersex, of course, being this really broad category that encompasses a ton of people, people with disorders of sexual development that are very different, the various disorders. And so again, this is really more of a dimension as well, but most places still kind of acknowledge it as kind of a checkbox type of category. And then finally, we have more of the sexual identities. They're at the bottom. Sexual attraction and romantic attraction. It's important to differentiate because some folks will experience one type of attraction and not others. Folks who identify as asexual, for instance, may deny and not really have any sexual attraction, whereas they may experience romantic attraction. And that's something that Chantal talks about a little bit in her video, how she doesn't really have a desire to engage in sex. But many people who identify as asexual are interested in partnerships and romance, but just not that added step. And so sexual attraction exists on a dimension of being attracted to women, those who are feminine, female people, to men, those are masculine, male people, neither, anything in the middle, both, and romantic attraction exists on the same spectrum. But again, it's important to differentiate the two. And again, everybody is different, so you should not assume that just because someone falls at one spot on one of these spectrums, that they'll necessarily fall at the spot you would expect them to on all of the other spectrums. So one thing that you might be surprised about is that anatomical sex is a spectrum too. That's one of the questions that I get a lot as an instructor is like, okay, I can wrap my head around how identity or expression or attraction could maybe vary a bit more, but isn't anatomical sex black and white? Like, after all, the sex you're assigned at birth still falls into one of three categories. So is it going too far to really think of this one as a spectrum? And at the end of the day, even though intersex kind of still exists as this category, there is so much diversity within that category. And if we were to kind of break that category up, it would exist very naturally along a spectrum, much like all of the other dimensions that I talked about. One of the reasons for this is because people naturally vary one person to the next. There's not in human nature and nature in general, there typically aren't these hard and fast lines and rules. So in the same way that people are born across a variety of heights and weights, people vary with respect to what it is that their anatomical sex looks like. One of the reasons for this is that there are a variety of causes. There are several female causes, several male causes, some examples of which are highlighted for you guys here on the screen. In a nutshell, the reason why sex can ultimately be dimensionalized as well has to do with how our genitals develop prenatally. In a nutshell, while chromosomes definitely play a role, the end determinant of what genitalia looks like is really hormones. And so, in a nutshell, I'll kind of break it down for you. So, all humans will auto develop as female. And it takes the presence of male hormones, androgens, testosterones, to allow those organs to develop further into the male organs. And so typically when a baby is born with an X chromosome and a Y chromosome, those chromosomes play a role in kind of ramping up testosterone and androgen production, which will cause the clitoris to grow further into a penis and which will cause the ovaries to eventually drop down as testes. Versus without that hormonal influence, the clitoris will develop alongside the vagina and the ovaries will remain inside the body. So it kind of makes sense if we think about it as having to do with hormones, that a person could be experiencing a variety of hormone levels, which could result in a variety of genital presentations, including what we sometimes refer to as ambiguous genitalia or genitalia that's somewhere in the middle. For example, one such female cause is something called congenital adrenal hyperplasia, which is basically a girl who's born XX chromosomes, but because of CAH, she has a higher level of testosterone production than normal. And so this can result in anything from just an enlarged clitoris to something that may be even more ambiguous than that. Mom having ovarian tumors can also be a potential cause that can contribute to genitals that are more in that intersex type of territory. As far as male causes go, and again, this is not an exhaustive list, one such cause is androgen insensitivity syndrome, which would be when testosterones and androgens are being released, but ultimately the body's not as sensitive to them. And so it's more or less like the hormones weren't even there. And so, again, this can result in anything from a smaller penis to something that's potentially even less ambiguous or more ambiguous than that. Beyond that, not everybody is simply XX or XY. There are a variety of chromosomal presentations in the middle. Klinefelter's, for example, is someone who has two X chromosomes and a Y chromosome. At the end of the day, while intersex is probably the more common label that we'll use to describe this particular presentation, disorders of sexual development is going to be the more PC term that we're moving towards, or DSD for short. And it's kind of tough to know an exact number in terms of how many people have DSDs, because typically if we're dealing with more of a larger clitoris or a smaller penis, typically those babies will either be assigned the labels of male versus female. And so it's tough to really get a true estimate. Beyond that, this still kind of exists as more of a taboo or sensitive topic, which can lead to people not kind of endorsing the fact that this is what they have or this is how they identify. But current estimates indicate that DSDs may impact about 1 in 2,000 births. So more common than you may expect them to be. So at this point, I would like you guys to pause and read The Humiliating Practice of Sex Testing Female Athletes. This is a really interesting read, and I'd encourage you to even read more about it. You can pull a ton of articles from the Times or Eureka Alert that are about this. It's basically the idea that, as far as many things go, sports being kind of the topic that we're focusing on here, that we like to break people up into male and female categories. So we have, women's track and field, and we have men's track and field. And this is kind of on the basis of this false dichotomy, this idea that everything exists in black and white terms, male or female. And that, again, even though we are starting to explore more the rich diversity that exists as far as sexual and gender identity goes, there is still this misconception that basic anatomical sex is still categorical, despite the fact that these other dimensions exist. But as we just discussed, this simply isn't the case. And so you have people who are in that DSD intersex category being singled out, particularly at the higher levels of sport, for not really being fully a woman or not really fully being a man. This tends to impact women more so than men. And the reasons for this are kind of sexist in nature. I would say that, men's sports are frequently viewed as being better or more competitive or more interesting than women's sports. And so, as a consequence, there's more public concern about a woman who trends more in the male direction, quote unquote, competing with other women than there is about a man who trends more in the female direction, competing with other men, if that makes sense. And so Caster Semenya is the kind of focal point that I've represented on this screen. And if you followed her at all over the past 10 to 15 years, I mean, her sex and her gender has been publicly debated internationally in a really humiliating form. Like, is she woman enough to continue to do what she's been doing her entire life? And it's even gone so far as to there being policies that women competing prior to an event or meet have to be able to demonstrate that their testosterone levels are below a certain level, and that might even entail taking a drug to lower their naturally higher testosterone levels. So intervening with nature in order to make them fit a particular box. So really interesting subject, a subject that, again, is based more on this false dichotomy of this black and white male femaleness versus these true dimensions. So read more about this, and this will definitely be a big discussion point that we will touch on during our next class meeting. But why spectrums? Why can't anything be black and white? Why can't things be simple? The answer is ultimately that dimensions add diversity. At the end of the day, when we have a species or a group of life forms that are too similar to one another in any number of ways, that just threatens the survival of the whole species. In that, if a threat to survival were to pose itself and all humans fell into one category or into one of two categories, that would make it more likely that that species could potentially be wiped out relative to if there was more diversity within a species, it would be much harder for one individual threat to wipe out an entire species. Beyond that, diversity within species is also really critical for the survival of our ecosystems. Again, if everybody was the same, then that would mean that we'd all have the same preferences for the same environments, the same ecosystems, which would overly tax those ecosystems and lead to them being wiped out. So at the end of the day, diversity is tremendously important for the survival of both species and ecosystems. And so for that reason, we have diversity not just with respect to our health and health-based predispositions, and we have diversity with respect to, um, our interests and where humans live and where different populations of humans are better adapted. But we also have diversity with respect to sexual identities, gender identities, and even things like anatomical sex as well. I'm going to talk a little bit more about homosexuality and some of the hypotheses that exist behind homosexuality, primarily because this is the area where more of the research is concentrated. And so that is what we're really going to be focusing on. But again, even though we're not talking about gender identities more so in this particular slide, just know that in a nutshell, any type of diversity is contributing to species and ecosystem survival, which is why those identities have emerged and persisted across time. So, what are some more specific reasons why homosexuality has emerged and persisted? One such explanation has to do with social bonding, and there is evidence for this particular hypothesis. In that people with a homosexual identity tend to have higher levels of the hormone progesterone, which is frequently thought of as the friendship hormone. So you might be familiar with like oxytocin as the love hormone. And so progesterone is the friendship hormone. And research suggests that people, again, with a homosexual identity have higher levels of progesterone, which makes them friendlier, quote unquote. And so, why is this important? At the end of the day, this may promote social bonding, which makes sense. We've got higher levels of this friendship hormone, and so that's going to be associated with friendlier, more social types of behaviors. Why is this important within a group? It's important within a group because if we've got everybody in a group who is heterosexual in nature and who is focused exclusively on finding a mate and reproduction, again, this is kind of thinking more historically, so we're kind of excluding the influence of modern medicine currently on reproduction. But if you've got everybody within a group who is heterosexual, focused on mate selection, focused on reproduction, that can create a pretty aggressive and hostile community. And so the theory is that it might make sense for the health of the community, for the health of the society, for there to be about 10% of people within that group who have these higher levels of progesterone, who aren't quite as focused on reproducing themselves, but are instead contributing to the social bonding of the community at large. And so we are focusing less on individual personal reproduction and more so on the health of the community and the reproductive success of the community. Similarly, um, another hypothesis is the worker bee hypothesis, and it focuses more again on this idea of it's going to be good for the community if not everybody within that community is focused on personal reproductive success and personal reproduction, but instead is focused more so on the community. So the idea here is that we're not reproducing ourselves, but we're kind of worker bees, so to speak, within the community, and we're focused more on adding to the child rearing capacities of other families. And some of this has to do with genetics and how much we pass on to the next generation. So I'm going to kind of back up for a second and talk a little bit about how closely related we are to certain family members. So anytime we have two people who mate and reproduce and create offspring, there's going to be 50% of genetic material shared across those offspring. So mom and dad each share 50% of their genetic material with their children. Similarly, siblings also share 50% of their genetic material with each other. And then each time we take a step further out from that kind of central core, we are cutting that genetic kind of shared space in half. So a child shares 50% of their genetic material with their mother, but they only share 25% of their genetic material with their grandparents, who are kind of one level above. Or alternatively, a child would only also share 25% of their genetic material with their aunts or uncles, their mothers and their fathers, brothers and sisters, because that's kind of one level out versus being one level up, like the grandparents. And so, if we understand this and we're thinking about reproductive success, one could be reproductively successful by having children themselves and passing 50% of that genetic material on to the next generation. Or alternatively, one could also be reproductively successful by choosing not to have children themselves and instead focusing on contributing to the caregiving towards one's nieces and nephews, because that's really 25% of your genetic material. And particularly if we're thinking back, long, long, long time ago, we're talking about a time where it wasn't a given that children would survive. And in fact, this is something that impacted us as soon as like 100 to 150 years ago. That's actually one of the reasons that human lifespan seems much shorter, even 100 years ago. In reality, people did live to an older age, even in the early 1900s or 1800s. But one of the reasons that human lifespan was so low is that child mortality rate was so high, and so it would drag the average lifespan down. I myself actually just bought the house that I'm in currently a couple years ago. And in kind of looking around the property, this is kind of a sad story, but I found a handful of tombstones from the 1850s, which was pretty cool. But all four of the tombstones are from children younger than four. So again, just 150 to 200 years ago, it was not a given that kids would live. And so it makes sense to have folks who aren't reproducing themselves, but who are instead contributing to the child rearing of other children, children who are closely related to them. And again, they can be reproductively successful in that way. And so that worker bee idea is another hypothesis behind homosexuality. The final hypothesis that I'll cover is basically just this idea of enhanced diversity that we've already talked about. And specifically, there's support for this idea via something called the older brother effect. Basically, research suggests that if mom has given birth to multiple children of the same sex. So in this case, we're going to use boys as an example. So mom's given birth to like 4 boys. There's a greater likelihood that the youngest boy will identify as homosexual than there is a likelihood of the oldest boy identifying as homosexual. The idea here, and again, this is just a hypothesis to explain that data, is enhanced diversity, that there might be something about mom and her womb that is identifying, okay, this is the 4th boy that we've produced. We need to promote diversity within the species. And so we're going to kind of steer biologically this child more towards a homosexual identity to at least promote diversity in that way. So again, that's just kind of a hypothesis of why that trend exists, but that trend of younger brothers of multiple older brothers having a greater tendency to identify homosexually, that is an empirically supported trend. And that explanation I provided is just kind of one of the hypotheses behind that. So again, these are just some explanations as to why we have this complicated gray system versus a simpler black or white system. Okay, so that is everything that is normal. So now we can switch gears into the abnormal, what is diagnostic. So gender dysphoria is the term that we're going to be talking about today. You may or may not be familiar with this term. What it is basically describing a transgendered identity that causes significant distress or impairment. So that's the key. That's why I bold that term at the bottom. That's why I bold the dysphoria. You guys know at this point, after having covered depression, that dysphoria means sadness. And so really what we're diagnosing here is a particular type of sadness, almost in the same way that when we talked about depression, we talked about PMDD and peripartum onset depression. Those were specific types of depression. And so again, I almost like to present gender dysphoria as a specific type of depression because there is a big misconception within the population that this is just something that all trans folks are labeled with, and that's why a transgendered identity is wrong or abnormal, is because everybody with that identity has this clinical label and there's something wrong. But at the end of the day, that's not what this is at all. This is really a particular type of sadness that is impacting trans folks. So we've got different sets of criteria for adults and teens versus children. For adults and teens, we need 2 or more of these symptoms over a 6-month period of time, which include an incongruence between expressed gender and sex, a desire to be rid of own sex characteristics, a desire for other sex characteristics, a desire to be the other gender, a desire to be treated as the other gender, or a conviction that one has the typical feelings or reactions of the other gender. As far as kids go, we're looking for 6 of these symptoms across 6 months. So you can see that wanting to be the other gender is pretty significant, but many of these other symptoms by themselves are fairly benign. And so for that reason, we're looking for a larger number. So preferring cross-dressing or preferring other gender roles, preferring toys stereotypical of the other gender, preferring other gendered playmates, rejecting toys stereotypical to one's gender or dislike of one's own sexual anatomy, or wanting the sexual characteristics of the other gender. So we need those symptoms. Depending on the person's age, you'll use that list, and then clinically significant distress or impairment as a result. At the end of the day, that distress comes from being prevented from engaging in desired behaviors and gender expression. So that's another big misconception about that label, is that people who are trans are just sad because they are the way that they are, and that it's their trans identity that's driving this depression. But in reality, gender dysphoria is almost like a culture bound syndrome, in that if as a community we could be more accepting of these individuals, then there would be more acceptance and there would be pretty much no distress, because for the most part, all of the distress associated with gender dysphoria comes from a lack of acceptance and from outward prevention of people kind of dressing or behaving in the ways that they'd like to behave, and sometimes being threatened with violence. So it is important to note that that's where that distress comes from, not due to a gender sex incongruence. So beyond that idea of gender dysphoria being like this culture bound syndrome that, really only exists potentially because we don't accept these identities more widely, there's additional evidence in that there are third sex gender options that exist within particular communities, such as India, Samoa, and within certain Native American communities here in the United States, the Cherokee community being one example. And so within these communities, there are men, there are women, and then there's typically a third name. So in this country and in other more progressive countries, there is a little bit more of a push towards using intersexed as a third label. And that's basically what these communities do regularly and have been doing for many, many years, is there's this third label. And so there is some indicator that potentially if we just had another label or more acceptance of this as just being part of the norm, that again, we might not really have gender dysphoria at all. Okay, so who is impacted by gender dysphoria? At the end of the day, we see it impacting both trans folks and folks with DSDs. And interestingly enough, you'll see that the prevalence rate among trans folks is very low. It is more common in natal males than natal females, meaning it is more common in trans women than in trans men. But at the end of the day, it impacts less than 0.1% of each. So very rare, not super common. So that's another misconception about this, is a lot of people associate gender dysphoria with the trans experience and the trans identity, but this actually impacts way more people with disorders of sexual development than it does people with a trans orientation. One of the reasons that we might see it more commonly in natal males or trans women is because there's that same pressure to fulfill the thin ideal that we see among just women in general, cis, trans, whatever. We see this pressure to pursue the thin ideal. But then there's that added pressure of there being this choice to present as a woman and kind of choosing to express in this way. So one quote that I really like comes to us from Our Bodies, Ourselves, and I've shared quotes from this book before. And it states, I've reached a point where I feel like a woman and see myself as a woman, but seeing myself as a man in dress hasn't entirely disappeared. When I catch my reflection in the mirror at a certain angle or see a picture of myself, sometimes all I can see are the parts of myself that scream man. I know many other trans women have felt the same way. So there's this, again, kind of same pressure for this ideal, the kind of this added pressure of this choice and kind of different starting points in terms of where we are at the beginning on this journey to pursue this ideal. Disorders of sexual development, or DSDs, as I mentioned, these really encompass more of the gender dysphoria group. We do see this more commonly among natal females than natal males. And with that, you kind of have to, if we're thinking about the dimension of anatomical sex, we're thinking about people who trend more in the natal female direction versus the natal male direction, or people who may have even been assigned female at birth, but at closer examination, potentially intersex is more of an appropriate label, or a label that that person identifies with more. So as many as 12 to 50% of natal females may identify with gender dysphoria, versus those numbers are between 2 and 30% of males. So the final thing that I want to talk about before wrapping up today is surgery. So again, because I know that a number of you guys are kind of health in nature, thinking about, exercise science, nursing, et cetera, I always like to cover surgeries or other types of more kind of health or medically based treatment options, just because that's relevant to you guys. So there are two different types of approaches that we'll talk about here. One is going to be the cosmetic genital surgery for children with DSD, and then the gender affirmation surgery for trans folks. So first up, the cosmetic genital surgeries are kind of based in this traditional medical model, and we saw them being used more so back in the 1950s. And the idea was that, anatomical sex is categorical. You've got two options. And so if we have a baby being born in the middle, it makes the most sense to identify which of these two options are they closest to, and let's use surgery to make them look normal, i.e. closer to one of these two options. And the idea is that we're going to prevent emotional trauma, that it would be really traumatic to grow up with intersexed or ambiguous genitalia. And so we're going to prevent that trauma by making a kid look normal, quote unquote. At the end of the day, though, research suggests that these childhood procedures that are done when the baby was born, or otherwise a kid and, can't really understand the situation or make their own decision, that in the long run, these surgeries are associated with health problems. impaired sexual functioning, because frequently, particularly if we're talking about the surgeries of the 1950s, the really old procedures, the idea was to make the person look normal, not to preserve sexual functioning. And so frequently, the tissue in the tip of the penis or the clitoris that is responsible for sensation and orgasm would typically be destroyed in order to make the genitalia look normal. And so sexual functioning could be impaired. The person could potentially never be able to have an orgasm. And emotional trauma was most definitely caused in these instances. Currently, it's recommended to wait until the child is a young adult and old enough to decide for themselves. So it's not recommended that you intervene surgically, but instead accept the child for how they are, accept the fact that everything is a dimension, wait until the person's older, talk to them about what's going on, and help them make a decision as to what it is they'd like to do, if anything. The second type of surgical approach that I will review is the gender affirmation surgery for trans folks. You may notice that the term is gender affirmation versus gender correction. This may seem like a nuanced change, but we have talked about language a lot in this class, so you know that language is very important to me. So gender correction isn't a great term because it's implying that something was wrong, versus affirmation is, affirming the person's gender and who they really are. For that reason, we also don't really talk about gender reassignment quite as much anymore, because if you guys will remember from the first slide, gender is something that's internal. It's not something that's ever really wrong. It's just how you are. And you're not assigning the person to a gender. They are who they are, and you are simply using surgery to affirm who it is they are. There are three phases to gender affirmation surgery. The person will live as their desired gender. This will include dress and how they socialize. And this is done, these phases are kind of done in this order, least invasive to most invasive, to kind of see where the person is comfortable. Because at the end of the day, not everybody pursues hormones or surgery. Some people are simply happy being able to express as they'd like to express, and that's it. Beyond that, surgeries, while they're getting better and better, they do kind of come with that risk of prioritizing physical appearance over functioning. And so, for that reason, not everybody chooses to pursue more genitally based surgeries either. So, living as the desired gender is the first step, exploring new preferred names, preferred pronouns, those types of things to kind of see, does this feel comfortable? Do we like this? Do we want to go further or not? If going further, hormonal therapy is going to be the second step, and the aim of this is to alter secondary sexual characteristics. So, to impact things like breast development, or body hair, things of that nature. Typically, if we're talking about a younger person, like a child, the hormonal approach would be to use hormone blockers to prevent puberty first. And then going forward, as the person got older, then we might actually be prescribing the opposite hormones to facilitate the hormonal change in the direction this person would like to pursue. Generally speaking, hormonal therapy will decrease anxiety, depression, and emotional distress. And these steps are also things that can be started at a very young age. It's not something that you have to be an adult in order to start. And in fact, starting younger has been associated with better outcomes. So if you have a child who feels like they're in the wrong body, who is giving you indicators of that sex gender mismatch that we talked about with gender dysphoria, whether or not that distress is there, that could be an indicator that this is kind of where this child is landing, and a good opportunity to start with that first step. And if that's feeling good, that could be an indicator to engage in hormone blockers as that child is approaching puberty. Third step, which again, optional, not everybody gets here, would be surgery. So these would be procedures aimed at altering more primary sex characteristics, or what the chest looks like. Um, Procedures are changing, as I mentioned earlier, so they do a much better job currently than they did in the 50s at enhancing functionality and sensation in addition to what the organ looks like. And 95% of people who pursue this step are satisfied with their improved body satisfaction and their relationships as well. Alrighty, so that is all that I have for you guys today. Nice, quick little lecture. And I will talk to you guys later. Bye.